طيب يا إخواننا، نبدأ. السلام عليكم ورحمة الله وبركاته. ورمضان كريم عليكم وإن شاء الله بخير. البرزنتيشن بتاع الليلة أو الموضوع بتاع الليلة مقسوم in two parts. Part 1 which is going to be presented by me, and it's about ICU management and cardiac complications of COVID-19 patients. Part 2 is going to be presented by دكتور محمد حسن دفع الله من الدفعة السادسة. He's an internist and an endocrinologist في Howard University هنا في Washington DC. He's going to be presenting neurological and hematological complications of COVID-19. فنحن هسه هنبدأ بال ICU management وال cardiac complications. والأتاك plan بتاعتنا هتكون the same like last time. زي البرزنتيشن الأخير بتاعنا إنه ما نمر مرور سريع وفي نفس الوقت ما نغرق. تمام، عايزين نعمل يعني we want to build a solid foundation للفهم ونمر على النقاط المهمة بتركيز كويس. فنقول بسم الله ونبدأ. لأنه هنتكلم عن ال ICU management which is management of all of the complications. عشان نفهم ونكون ماشيين بفهم we're gonna brush off our pathophysiology. The same thing that we spoke about last time, we're just gonna be reviewing it and refreshing our memory عشان لما نكون ماشيين في complications نكون كلنا we're following together. As we said last time, SARS CoV-2 virus, the spikes بتاعته ال S proteins will get inside the cell through the ACE2 receptor or the angiotensin enzyme receptor, angiotensin converting enzyme receptor 2, which is abundantly available in the lung. برضو in the heart, it's also present in the kidney, it's also present of the ileum, the small intestine, and to a little extent also in the bladder and other tissues of the body too. And that's part of the mechanism of the damage that happens in all over the body, in every system, every organ. Part of that is due to actual direct inflammation caused by invasion by the virus, viral replication inside the cell, and then subsequently damaging the cell. Then الجزء الثاني من complications is due to the overall host immune response. يعني for the immune system to try to mount an immune response to clear the virus, the damage that happens due to this severe immune response is also responsible for a big part of the comorbidity, a big part of the morbidity associated with the disease and the mortality, unfortunately. فقلنا the virus will gain access to the cells, whether it's in the lung, the heart, whatever, and inside the cells it will start to replicate. الريبليكيشن بتاع الفيروس, the virus will synthesize thousands and millions of copies and then eventually will damage the cells in its attempt to exit the cells, in the release attempt to damage the cells, and the damaged cell will release, of course, cytokines, and the cytokines will recruit cells. طبعا the cell that was invaded inside the alveoli, because the virus gets in through the airway inside the alveoli, the cell is the type 2 pneumocytes, which is the cell that is primarily responsible of secreting surfactant. So those cells are damaged by the virus, and then inside the alveoli there are immune cells. يعني inside the alveoli there is type 1 pneumocytes, which is mainly functioning in gas exchange, type 2, which is mainly functioning in releasing surfactant. There is also immune cells, which has immune functions. There is macrophages, there is some polymorph nuclear cells, there is dendritic cells. So those cells get recruited, mostly initially the macrophages and the dendritic cells, and then they will start to release also inflammatory cytokines, interleukin, 15, 12, 1, 6, 21, tumor necrosis factor, GM-CSF, and other factors. As we said last time, we usually focus on interleukin 6 and tumor necrosis factor because they're responsible for most of the systemic features. They're responsible of the fever, the hypotension, the significant sympathetic drive with tachycardia, and low blood pressure with decreased organ perfusion, which would eventually lead to when you decrease the organ perfusion to the brain, you get altered mental status, lethargy, sometimes even significant ischemia there with its consequences. When you decrease blood flow to the heart, you end up with relative ischemia, which could sometimes cause some damage to the heart muscle and leakage of troponin. When that happens in the kidney, you end up with also kidney damage and acute renal failure or kidney injury. This is one part of the pathophysiology, which is the severe response of the immune system that end up causing a lot of damage. Another thing is the disease process itself, or the actual infection with the virus itself and the damage happening to the cells themselves. So يلا ده منظر ظريف برضه عاوزين نتذكره لأنه we're going to be focusing a lot on ARDS management and management of respiratory failure or ARDS-like disease or respiratory failure that happens with COVID-19. So نركز في الصورة دي برضه. دي الالفيولاي هنا، ده البلاد فيسل around the alveoli مع اسمه شنو الانفيجن of the virus to type 2 pneumocytes and the damage that happened to type 2 pneumocytes, we get neutrophils and macrophages and polymorphonuclear cells, which will mediate the inflammatory response and release the cytokines. The cytokines themselves and the releasing of the polymorphonucleoside, like the neutrophils, when they come and they try to attack the virus and kill the virus or the virus infected cells, they start releasing oxygen, reactive oxygen species. And those reactive oxygen species like H2O2 or the other reactive oxygen species will end up damaging infected cells and normal cells, healthy cells like the type 1 pneumocytes, which will start the process of impairing oxygenation by damaging the type 1 pneumocytes. There is another component also, which is damaging type 2 pneumocytes will decrease surfactant. And when you decrease surfactant, the tension inside the alveoli, surface tension will increase, and the ability for the alveoli to collapse is higher now. Besides that, the cytokines will go to the surrounding capillaries and cause endothelial damage and vasodilatation. And with the vasodilatation, there will be leakage of a lot of inflammatory fluid, which is protein-rich fluid that will fill the alveoli and also surround the alveoli. The fluid that gets inside the alveoli will end up washing out more surfactant. So now we are very low on surfactant because المصنع وقف, type 2 pneumocytes are not working, and whatever we have is being washed out by this new fluid that's filling the alveoli. So now we are very high risk of collapse in this alveoli. حاجة بتزيد الطين بلة لأنه the same fluid that's accumulating inside the alveoli is also accumulating around the alveoli, and it's increasing the pressure on the alveoli and eventually will end up collapsing this alveoli. And when we come to discuss ARDS and ARDS management, we'll talk about recruitment, de-recruitment, and how we're losing airway and how come there is shunting of blood flow from areas that are basically de-recruited and it's not functional because of all of this collapse that happened due to what we discussed now, the washout of the surfactant, besides the poor production from the inside and the pressure from the building up of secretions from the outside. طيب عشان ما نطول هنا هنمشي. طيب اتكلمنا شوية عن what's happening in the lung and what's happening systemically. The slide from the last presentation, just to refresh our memory, who ends up getting severe disease, who's نحن هنتكلم عن ال ICU management. Who are we going to see in the ICU? Mostly people who are elderly, as we said, because في initial phase when you need your innate immune response, elderly population, they have a sluggish innate immune response. So the viral replication is pretty significant in the elderly. And when you need to recover, to regenerate your epithelial membranes and your cells and get better, the elderly population have a very also diminished ability to regenerate and recover. So they end up with the most severe disease. Also, other people who have other comorbid condition that either affects their immune function or their physiology and ability to handle all of the stress and the systemic inflammatory response that happens. People with cardiovascular disease, diabetic, hypertension patients, patients with COPD or asthma or any other lung disease, cancer patients, CKD patients, and obese patients, besides other immunosuppressive diseases, IgA deficiency, HIV, patients taking steroids or immunotherapy or chemotherapy or others. So besides the risk factors, if you see someone who has the disease, some signs that will make you predict that this patient is going to be someone that I'm going to probably see in the ICU. This patient is probably going to be someone who's going to develop a poor outcome, starting from their symptoms and vitals and physical exam findings. People mostly who have severe shortness of breath, people who have significant tachypnea with significant desaturations, less than 90, tachypnea respiratory rate more than 30, people who have increased work of breathing, use of accessory respiratory muscles. Those are the people on physical exam, and from the history you can tell they're probably going to end up in the ICU or with an adverse outcome. Labs, elevated D-dimer is also a marker that this patient is probably going to end up with severe disease. Lymphocytes less than 0.8 and elevated LDH, lactate dehydrogenase also. As we said last time, you can also calculate their curve 65, which is the pneumonia score that you use to basically place patients or dispose patients. If the patient scored 1, you can probably manage either at home or in the hospital. 2, you definitely have to keep them in the hospital, in the medical floor, but anybody who scored more than 2, they should go to the ICU. So those are the types of complications that we will see in the ICU. I did put a question mark besides ARDS because it's really not classic ARDS. I actually was talking to one of our ICU faculty members a lot about this, about just let's not talk about the pathophysiology or the management or the nomenclature. You have been managing ARDS forever. Would you call this ARDS at all? And he hesitated a lot, and eventually what he said was, I would just call it COVID-19 lung disease type L and type H, as we are going to see later. But he said I would not call it ARDS because it's definitely not classic ARDS, and we will see all of that later. But what I meant is acute respiratory failure. Also, other complications that we will see in the ICU is acute renal failure, arrhythmias, acute coronary syndrome, myocarditis, shock, thromboembolic complications, which will be discussed in details in the second part of this presentation by Dr. Mohammed Hassan Dafa'allah, inshallah. Stay tuned for that presentation too after this presentation. I'm going to try to make my presentation quick, inshallah. Also, the cytokine release syndrome with shock and multi-organ failure and other neurological and other complications. طيب, um, you have your patient, the patient is in the medicine floor and is deteriorating, and now you're transferring them to the ICU. What are the principles of care for a COVID-19 patient as we detailed in the last presentation? Number one is definitely isolation and prevention of disease spread. Patient has to be isolated in a room with negative air pressure, if at all possible, and you have to wear protective equipment to prevent disease from spread. You are very important because you're caring for a lot of people. If you catch the disease, you might end up inadvertently spreading the disease to your coworkers, your patients, your family. So definitely keep an eye on this point. The other part of also the hospital management is monitoring, which is critically important in the ICU because patients could become unstable, develop complications or anything at any point. So close follow-up and monitoring of their vitals, putting them on cardiac monitor, monitoring their oxygen saturations, examining them daily or more than that if needed. And if the patient is not intubated and can report symptoms, then of course you check with them how are their symptoms progressing or regressing. Also, part of the monitoring is labs and imaging. And then the other part or component of care in the hospital is, of course, managing the complications as they ensue and starting them on appropriate COVID specific agents. Of course, no visitation should be allowed in the ICU except for very limited circumstances. Someone who's terminal, you do have enough staff. Only one, maximum maybe two family members, maximum, would just come be with the patient for a short, brief period, supervised with the staff so that they're not touching stuff, and supervised with the staff actually from the time they step in the hospital until the time they leave the hospital and not the ICU. And other than that, it should be a no visitation policy in the ICU. Protective equipment, which will be discussed in it's a very important topic, so it will be discussed inshallah by Dr. Muhammad Al-Hadi, Muhammad Al-Yasin from batch 2. I believe his presentation is tomorrow. I'm not sure. Probably someone could put it for us in the comments. About PPEs, I did put this picture which is showing droplets containing the virus just to remind you that the ICU is a place that is filled with procedures that are aerosol generating. So you have to be very careful, always wear your N95 mask in the ICU, eye protection and stuff like that. So monitoring, as we said, blood pressure, heart rate and rhythm, oxygen saturation and respiratory rate, plus monitoring of central venous pressure if we need to, urine output, daily weight, and other stuff. If possible, the least amount of healthcare workers should be in the room. We should never have anybody more than what's critically needed to care for the patient. There is no such a thing. This is rounding time. هنخش مع الكونسلتنت كلنا when the team. No, only whoever is needed to just care for the patient. نحن في التيم بتاعنا الريزيدنت بيشوف البيشنت الصباح مثلا. لما نجي أنا للراوند I don't take the resident with me again to see the patient or again even if that يعني التيم بيكون فيه 4 or 5 residents. I'm not going to take all the team with me to the patient room. I'm not even going to take the resident who's responsible for the patient with me again to the room. They saw the patient once in the morning, that's it. So the least amount of personnel necessary to take care of the care episode should be in the room and not more than that. Another thing here is if you have 10 patients, they're all COVID positive. Uh, Especially in the ICU, it's better to put everyone in a separate room. But if resources are not that helpful, they all have COVID. There is no problem with putting them all in the same room as long as none of them have another condition that could be transmitted to the other patients. If resources are tight, you can lump more than one patient in the same room if they only have COVID and not other infectious conditions. Monitoring, as we said, heart, pulse, central venous pressure, especially in patients who are intubated, shock patients. We would like to monitor their central venous pressure to check their volume status. Usually through a central line. The central line usually goes either in the internal jugular vein in the neck or the subclavian vein. To keep a close eye on their volume status and central venous pressure. You sometimes would have to put in an ART line if you need close follow-up of the blood pressure and arterial line, which goes usually in the radial artery, to keep a close eye on the blood pressure. Usually, if you're not that interested in blood pressure monitoring, like the patient's blood pressure is stable and you're getting good reading with the normal cuff blood pressure machine, you don't have to put an ART line because it's an invasive procedure. Putting an arterial line is an invasive procedure and it does have a 5 up to 5% risk of complications, which could sometimes include ischemia and stuff like that. So if you don't have to, if you're not interested in close following up of blood pressure, don't put an ART line. But if you are, if the patient is in septic shock, blood pressure is soft, then this is better to keep a close eye on the blood pressure minute by minute. Everybody with COVID-19 in the ICU should monitor their urine output because they develop kidney issues, and you also want to check their input-output chart because becoming volume overloaded is one factor that will make oxygenating them more difficult, as we will come across in our coming slides. Checking daily weight also as a part of intake output monitoring, examining them. As we said, don't detail your exam, just stick to the basics stuff. Check the lungs, check the heart, check the belly if there is any tenderness, and just examine whatever else is relevant to you. If you want to check the skin, make sure there are no sores, ulcers, developing cellulitis or something, or any infection, maybe, but you don't have to do full neurological exam, full cardiac exam, full chest exam with percussion and blah blah. You don't have to do all of that. Just simple auscultation of the chest and of the heart, just the basic stuff. Try to spend, if you can, less time besides the patient. It doesn't mean compromise the care, but definitely don't do anything that's not necessary. Also, labs. So the labs that we need to do, as I stole this slide from the last presentation, also the daily labs would be the CBC with differential, with a special focus on the lymphocyte count and the trend of the lymphocyte, because a lymphocyte trend will give you an idea about whether the patient is improving or no. And also a complete panel in which you'll check the important stuff, which is kidney function, because those patients develop kidney complications, urea and creatinine. Electrolytes, mostly potassium, magnesium, and sodium. And if you can also check the liver function, this would be great too, transaminases, AST and ALT. If you can't check all of this, I would prioritize checking kidney function, urea, creatinine, and electrolytes, potassium, sodium, and magnesium, potassium and magnesium mainly. The rest of the stuff would give you a marker of worsening disease, but you can check that clinically. But this is crucial for management, is kidney function and electrolytes. The liver enzymes usually don't, most of the time, don't end up going way too high. So hopefully you can get away without having to check it every day. Other markers, which are also markers for severity, is LDH, ferritin, uh, um, PT, PTT, D dimer, and interleukin 6. Those are markers for severity. Uh, the ones that are crucial, that are actually significant to help you manage the patients, are the troponin. If the troponin is elevated, you of course have to evaluate what's the cause of this troponin elevation, and the management will differ. The D-dimer, because as we will discuss later, if the D-dimer is elevated, the patient might be a candidate for anticoagulation, therapeutic anticoagulation. Interleukin 6, also because that if that's elevated, it's a marker of a cytokine release syndrome or cytokine storm, and there are specific treatments for that, like the interleukin 6 monoclonal antibodies, although they're not available in Sudan, unfortunately. And EKG is also very important. Every patient should get an EKG on admission. To summarize this, every patient should get a CBC, CMP, troponin, EKG on admission, D-dimer on admission. Those are very, very important. You have to get them on everybody. EKG to check, are they sinus, do they have any rhythm issues, and most importantly, check their corrected QTC or QT interval. The C stands for corrected. If you're starting the patient on any medication that could prolong their QT, repeat their EKG again. And if it is high or borderline high, you could follow it up, like check an EKG every other day or every day. We would like the QTC to be less than 500. If it is less than 500, then you can start your agents, but keep a close eye in anybody their QT is more than 470, because that's technically elevated and they have a higher risk of progressing to significant prolongation and then polymorphic ventricular tachycardia, which is a malignant rhythm that could be fatal or degenerate into something fatal. On admission, also a chest X-ray is important to be done. It's not important in the ICU. Some IC intensivists would recommend doing an IC and a chest X-ray daily. It's not indicated for COVID-19 patients, both because it's useless and because it's just too much exposure for a lot of healthcare providers, the healthcare workers to just take the patient to get the X-ray or bring the X-ray staff to film the patient in the ICU. If indicated, CT, but the indications are very limited. I would only say it's indicated if I'm suspecting this patient has, let's say, a PE, and I want to do a CT with contrast because I'm suspecting this patient might have a PE. That's an indication, but otherwise I would not do it just to look at the lungs and the COVID features. Another thing is the echo. If the troponins are elevated, if the patient is developing arrhythmias, if I'm suspecting myocarditis, or if the patient had elevated troponin, I would check their echo. Procalcitonin and cultures for bacteria are not indicated routinely unless if you suspect. If you suspect this patient has a secondary bacterial infection with actual clues there. We spoke about the X-ray features of COVID-19 being bilateral and in the basis. If you have a clear lobar presentation, a lobar pneumonia, then this is more suggestive of bacterial. Then you could check sputum culture, you could check blood culture, you could check procalcitonin, but otherwise bacterial co-infections or secondary infections are rare. So try not to waste your time, the patient time, resources in ordering unnecessary testing. Other viral co-infection, if you're suspecting the patient might have influenza because the patient reported on history that they have symptoms of influenza, terrible body aches and congestion and stuff, besides being COVID negative, if you think they could also be influenza positive, and you could give them influenza medication, which is the Tamiflu or oseltamivir, which I don't think this is an issue في Sudan نهائي, but this is an exception to testing people for other viral infections. But it doesn't matter if they have RSV or rhino or any other viral infection, because we don't have specific treatments for them anyhow, so it's pointless to think about them. The only thing that is helpful maybe is influenza, which is not relevant for us in Sudan anyhow. Okay, so the pillars of ICU care for COVID-19 patient. Of course, management of respiratory failure, of course, is management of shock and hemodynamic support, and then management of other complications. This is the most common complications that people run into, is respiratory failure and ARDS-like disease. Shock, and then after that, renal complications will be the next commonest, cardiac, and then thromboembolic, and then neurological, and then others. The renal complications were covered by Dr. Mohammed Anwar Ghandour in his session about 3 days ago. Please review that lecture, because from the last time that we did talk كان في 318 عيان بتاعين أنا عينت السلايدز بتاعتي من المرة اللي فاتت، في 318 عيان بتاعين كوفيد 19 في السودان. الليلة في 930 عيان، يعني النمبر tripled. والdeaths used to be 25, today it's 52. يعني the disease is spreading. إن شاء الله ربنا يحفظ البلد، وربنا يعني كده ينتهي الموضوع ده على الحتة دي. لكن as you start to see more patients, you need to know as much as you can about severe disease, about complications, about what can I do to help them. Educate yourself شديد so that you can be on your feet, you know what to do. Those patients deteriorate very quickly, so you really don't have the luxury of not knowing, of waiting to ask the registrar, or waiting to ask the consultant, or waiting to check on the internet or something. You don't have the luxury to do that. You have to be up on your feet. Everything should be in your mind. You should be comfortable with this. So try to educate yourself as much as you can. I would definitely recommend going back to the nephrology lecture, reviewing what Dr. Ghandour spoke about in details there. We're going to be covering cardiac, thromboembolic, and neurological complications today. I'm going to take care of the cardiac part, and the rest is going to be covered by Dr. Muhammad Hassani, Dafa'allah. So this slide is just about what we spoke about last time, the supportive care for the patient. So oxygen, initially we would use a nasal cannula, which would give us anywhere from 2 to 6 liters. We're all familiar with the nasal cannula, the regular nasal cannula. If the patient did not do well on the nasal cannula, then you could go to a non-rebreather mask, which could give you up to 15 liter oxygen and up to 80% saturation, FiO2. And if that did not do the trick, then you go to high flow nasal cannula, which is a high pressure system, which could give you very high speeds and high FiO2 as high as 100%. If the patient did not improve with the high flow nasal cannula, then you just go ahead and you intubate them, put them on mechanical ventilation. It's advised to avoid CPAP and BiPAP, just because of how much aerosolization of the virus that they do create, and the risk for healthcare workers. High flow nasal cannula could technically possibly also generate, because of the speed of the flow, generate aerosolization. So, but it's a nasal cannula, so it's what we usually do is just put a regular mask on the patient's face, not the N95 mask, but the regular surgical mask on the patient's face to decrease the risk of aerosolization. Of course, we spoke about prone positioning for anybody with increased oxygen requirement, whether conscious proning, with you asking the patient إنه بس يعني أرقد على بطنك أكتر. يعني once العيان أنا لقيته العيان قاعد في 2 liters خلاص, I'm going to keep my fingers crossed, keep them on their management, whether it's hydroxychloroquine or whatever we're treating the patient with, and continue the other supportive therapy, follow the labs and stuff. and we should be good. Let's hope for the best and see how things would go. If you start to need anything more than 2 liters, then I will start talking to you about prone positioning and laying on your stomach to improve oxygenation, to help with the recruitment and decrease shunting. So proning, or prone positioning is important. For anybody who's on more than 2 liters, suggest voluntary proning or conscious proning. In the patients who are intubated, type H patients or late disease patients, proning is a very essential part of their management. Fever and pain management, as we discussed last time, Tylenol or acetaminophen or paracetamol or albenadol, and do not use non-steroidal agents to start with. If you don't have a strong indication, do not use it for fever and pain management. Try to stick with acetaminophen or paracetamol or Panadol. IV fluids, if you don't need IV fluids for resuscitation, someone is hypotensive or clearly dehydrated and has a pre-renal injury, kidney injury, don't use IV fluids. Try to keep them mostly on the dry side, especially if they have a good input. Someone who has good oral input, they're not spiking high fever, don't put them on IV fluids. DVT prophylaxis for everybody that is admitted to the hospital. Everybody who's admitted to the hospital, put them on DVT prophylaxis. They have a higher risk of thromboembolic phenomena, so put them on DVT prophylaxis. The recommended agent is enoxaparin, 40 milligram daily. You could use unfractionated heparin also, the 5,000 3 times daily, and both of those medications are under the skin. They're sub-Q injections, subcutaneous injections. Avoid nebulized medication. The nebulizer دي avoid it. Try to use inhalers. السبيسر devices دي available في الصيدليات في السودان. أي زول بياخد inhalers جيب spacer, hook it to their inhaler and use it. Don't use the nebulizer because it aerosolizes the virus also. Empiric antibiotic, maybe when the patient came to the hospital and you don't have the test result yet for the corona, you can cover them with antibiotics and argue that it could still be bacterial pneumonia. But as soon as you get your corona test and it's positive, stop the antibiotics because they have their side effects, and bacterial co-infections or secondary infections are very uncommon. So don't. Some antibiotics prolong your QT, some antibiotics affect your kidney numbers, some affect your liver, so try not to put the patient on antibiotics unless if you have an evidence of bacterial infections. Steroids is discouraged, whether inhaled or systemic, unless if you have an indication, like asthma with an exacerbation or COPD with exacerbation or something like that, then you could use it, but otherwise it's discouraged. We spoke last time about ARBs, not to start them, but if the patient is already on them, you don't have to discontinue them. Although I noticed a lot of the patients, even the ones that don't deteriorate and they stay in the floor, they still drop blood pressure. And if they started dropping blood pressure, just discontinue ACE and ARBs. Statins, some people are hesitant about using them because of the elevated liver enzymes. If the elevation is significant, you can avoid them, but some people at the beginning of the disease were arguing for their benefit because of their anti-inflammatory effect. This is the non-rebreather mask that we spoke about. It does have a one-way valve and does have this reservoir here, this bag, and it does give up to from 60 to 80% oxygen saturation and up to 15 liter flow. So it's definitely superior to the regular Venturi mask and the nasal cannula. I think we already spoke about this. IV fluids, we said try to avoid. In some patients, we even end up diuresing them. DVT prophylaxis for everybody. In some cases, we end up putting them on not just a prophylaxis dose, but on a full therapeutic dose. All right, so the high flow nasal cannula system, which is the next step, this is the system, the high flow system, and it would basically, those are the numbers that are important for us when we're using the high flow nasal system. The FiO2, which is the saturation that you're giving of the oxygen that you're giving the patient, and then the flow rate, which is the speed in which you're pushing the oxygen with this patient, 40% oxygenation or FiO2 oxygen, and 25 liter per minute, which is a high speed. This thing could deliver up to 60 liter per minute. 60 liter per minute. Some devices could go up to 100, but most commercial devices are up to 60 liter per minute. And this is the humidification and the heat. It's a heated humidified delivery system. So this is something that you also have to set, which is the 37 degree Celsius, the temperature, and then just ask the patient, is this too warm? Is this too cold? Do you want me to heat it, go up on the heat or down? So just check with the patient. I usually would definitely not, because when you started, the patient is probably desaturating and maybe unstable. I would definitely not start at 40% or at 25. I would start with the highest setting. I would start with the 100%, 60, and then just as the patient becomes more stable, I would come down on it until I get to the patient's actual requirement. So there is a difference, of course, between the FiO2 and the flow rate. Both those individuals are both breathing room air, but the only difference between them is the flow rate. The flow rate here is definitely not as high as here. So make sure that you pay attention to both your flow rate and your saturation, and adjust both of them differently. It doesn't matter if you put the patient on 60 liter if the FiO2 is not high enough. So make sure you adjust both of them separately to increase the patient comfort. Adjust the temperature and check with the patient. If they're not happy with the temperature, adjust it. This is a very helpful device to prevent intubation. It's the high flow nasal cannula. If patients are on the high flow nasal cannula, but they start to deteriorate on the high flow nasal cannula, those are the patients who need to be intubated. It's definitely helpful. A high flow nasal cannula is helpful. I myself have seen it save a lot of people from being intubated. They go to nasal cannula and they stay on high flow nasal cannula for a few days, and then they improve, and then they get better, and then they go home. It saves them from intubation. But once you get to that stage, once you're on a heated high flow system, your risk of deterioration is high, and the deterioration happens really quick. So those are the patients that they need very close observation and monitoring. So monitor them very closely, those patients. Anybody who's desaturating on the high flow, high FiO2, or has increased work of breathing on high flow, high FiO2, those are the patients that need to be intubated. Anybody who has altered mentation and cannot protect their airways, they need to be intubated. So before we go to discussing intubation and mechanical ventilation, let's talk about the lung disease that we find in COVID-19. As we discussed in our previous presentation, there are two types: early disease or type 1 with a light lung or L, late disease or type 2 with a heavy lung or H type or L type. So in L type, there is not a lot of inflammatory proteinaceous fluid filling the lung. So there is low lung weight and low lung water. In contrast here, there's a lot of fluids filling the lung, and especially in the dependent areas in the back, and heavy lung. And once you have heavy lung and lung filled with fluids, you know that proning will help move the secretions, get the secretions out, improve your aeration, get all of this area, which is very big here, to be aerated, and this will improve oxygenation and will decrease shunting. So proning is a very essential component of management of the type 2 disease. So we have high water, low water, significant disease on imaging, pretty much not very much seen on imaging here. The elasticity of the lung here is very high and the compliance is very low. The elasticity يعني انت لو عندك مثلا نقول بلومة ولا الستيكة بتاعت قروش ولا كده، لما تكون بتتمطى تمام معاك تفتح تمام لبرا، ده الكومبلاينس بتاعها. الكومبلاينس بيكون very poor هنا في تايب 2 ده، لانه في انفلاميشن كتير وفي كومبريشن على الالفيولاي من برا، فالالفيولاي ما دايره تفتح. الكومبلاينس بتاعها is very low less than 40. هنا لسه الشغلات دي زي ما شايف on the CT scan او شايفه on the CT scan الكومبلاينس is low, الكومبلاينس is I'm sorry is good and the water is low وكده. at the same time عكس الكومبلاينس is the elasticity، يعني الاستيكه دي ما بتفتح والبالونه ما بتفتح كويس، بالعكس جرة على جوا، يعني الريكويل is high. هنا الريكويل والكولابسابيليتي والكولابسing tendencies are high. الإلاستنس is high. هنا الإلاستنس is low. Water is high, water is low, water is high. And VQ match, once you have a lot of airways that are not functioning, they become basically dead space. They're not oxygenating nothing because they're full with fluids and stuff. So the body to act smart or يعني it's a protective mechanism. We don't send blood to the alveoli here because they're not working. We shunt most of the blood to the functioning alveoli or alveolar units here. So they have high shunt here. Those ones, because the disease is not that extensive, their shunting is low here. And as we said, the pictures would tell you the difference. I spent a long time here because if you understand this, you'll understand mechanical ventilation of COVID-19 patients, if you understand the difference between those two. This one is more similar to classic ARDS and will need management that's more similar to classic ARDS. Over here, that's not the case. So let's talk about mechanical ventilation. So the intubation, how do we intubate people, and the procedure, which is very important. Serious critical procedure that's significantly aerosol generating procedure will be discussed also by Dr. Mohammed Al-Hadi in his session, I believe tomorrow, if someone could just confirm in the comments. But I'm going to talk about the patient is intubated, now you're managing the machine. What should you do? What mode should you put the patient on? You should put the recommended mode is AC or assist control, which is a volume control mode, and you have to set the tidal volume. The tidal volume that you should set should be on the lower side, especially in late disease. In early disease, you could probably get away with using slightly higher volume, but as disease progress, it's recommended to use lower tidal volume. The goal should be 6 or less, 6 ml per kg. يعني زول وزنه طبعا you don't use the patient weight, use the ideal weight. يعني انت we don't care about انه في شحم وزول ده سمين. That doesn't matter. What matters is how much can the lung take, because this is the tidal volume. If you push too much في lung, you distend the alveoli and you end up يعني زي مثلا تخيل مثلا أو تخيلي مثلا يعني your lip، يعني شفتك للناس اللي عندهم شفة، أو شلوفتك للناس اللي عندهم شلاليف. في ناس عندهم تلاليش طبعا لكن ما علينا بهم. فتخيل شفتك أو شلوفتك، تخيل زول مسكها ومطاها شديد، مطاها 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 مطاها. what could happen؟ ممكن تتقطع أو تتجرح. مش حتى لو ما اتقطعت أو ما اتجرحت هيكون في pain شديد، يعني هتحمر وهتوجعك كم يوم وكده. وهنا ليه؟ لأنه it was pulled really tight. don't do the same thing to those patients lungs. احنا قلنا هنا انه الناس ديل they have low compliance. اللنج بتاعتهم ما بتتمطى، فما تديهم big tidal volume because هتمط شلاليفهم او شفايفهم to a very significant extent that you will end up damaging their lungs and you could kill them. Trying to ventilate them, you could kill them. فديل هنا they need protective ventilation with low tidal volumes. This is very important هنا في الناس دي. They have high elastance, so their tendency is to basically collapse and close, but their recruitability is high. You can recruit more airways here if you give them more PEEP or positive end expiratory pressure. If you give them more PEEP, you could open up your lungs and you could use the smallest tidal volume to keep protecting their airways, their lungs, because once you exert too much pressure يعني زي الشفايف أو الشلاليف المجرورة، لو ما اتقطعت يعني لو ما الالفيولاي دي طرشقت وحصل زون نيوموثوركس، التنشن الشديد على الشفايف ده هيعمل لك احمرار ووجع شديد، وهناك على الالفيولاي التنشن الشديد ده هيعمل لك release of inflammatory mediators و worsening ARDS وفي النهاية worsening outcome و death. احنا اصلا ال ARDS دي كلها من inflammatory mediators، تجي انت بالفنتيليتر تزيد الطين بلة وتكتر الزول والموضوع يخلص. ف be careful. low tidal volumes especially هنا لما نجي الحتة دي low tidal volumes، لأنه يعني أول ما المرض ده بدأ الناس كانوا بيقولوا لا this is not ARDS and lung D is very compliant، الناس دي كويسين let's give them bigger tidal volumes and low PEEP and stuff، and الناس ما كانوا they did not pay attention إنه people transition to this disease. فعشان الناس were not paying attention للترانزيشن اللي بيحصل ده they used to continue the same settings and damage the lungs. When the patients get here يعني انت عندك اللنج دي انت ضاخي فيها مثلا نقول 500 ml بتوزع في التو سايدز ديل بصوره ظريفه وكده وهناي. هنا انت هتضخ 500 ml ده كله مع في التهد ده، 500 ml دي هتتحشر هنا فما هتفيد محل تتحشر فيها، فهيكون في significant distension. Maybe you'll get a pneumothorax, maybe you'll get pneumodistinum or whatever, or if not, you'll definitely end up with worsening disease, worsening ARDS, and then you'll kill the patient ventilating. So be careful. Preventive ventilation is very highly recommended. So lower tidal volumes. initially قلنا زي ما قلنا هنا they're responsive، فممكن تديهم يعني 6 to 8 قول هنا in this type 1 or L 6 to 8 volume and lower PEEP like 5 to 8, 5 to 10. Once you transition to here, which you will feel it with the machine and you will feel it with imaging, then you have to drop your volumes to 6 to 4 and go up on your PEEP. We're gonna talk about that. So this is enough about volume and PEEP. Respiratory rate, of course, you start at 18 and then you just titrate based on your PCO2. And check an ABG, look at the PCO2, and then depending on the PCO2, you titrate your rate up or down, depending if the patient is retaining PCO2 and PCO2 is going up, you go up. If the patient is washing out with this 18 and their PCO2 is low, then you slow them down to 14 or something. The FiO2, the same thing as we said with the high flow nasal cannula, start at 100% and then titrate down. Don't start low, start high and then titrate down. Start high to salvage and save the patient, make sure that you're reoxygenating them, protecting their brain, their myocardial tissues, and then you can always titrate down. So this is the from the ARDS clinical network. This is the PEEP FiO2 schedule. You could review it. So you intubated the patient, you started them on appropriate volumes. I hope I was able to give you a good understanding of the principles of how to ventilate those patients. But after you did put the patients on those settings, look at their work of breathing, look at their synchronization with the vent. Are they synchronizing well, or are they still trying to trigger at inappropriate time and try to take extra breaths? Do they need more increasing the FiO2 if their PO2 is low on the ABG? Do they need their rate to be increased if their PCO2 is high, or their rate to be dropped if their PCO2 is washing out and their PCO2 is 24 or something? So monitor ABG, monitor clinical response, and also very important for management is monitoring pressures. The plateau pressure is basically the pressure inside the lung, inside the alveoli. And you're giving the patient tidal volume and you're giving them PEEP, and you want to know what is the pressure inside the lung. So you measure the plateau pressure with the machine. من الميكانيكال فنتيليتر ذاتها بتعمل inspiratory pause end inspiratory pause، يعني الزول دخلت النفس ووقفت على كده ودرت اشوف الضغط جوا كم. عرفت الضغط كم؟ المفروض يكون less than 30. If it's more, you're probably giving the patient too much and you need to cut down your volume, otherwise you will end up causing barotrauma to the lung. So be careful with how much you're giving the patient. What is more important than plateau pressure is the driving pressure. The driving pressure is basically the plateau pressure minus the PEEP, and it should be less than 15. So whatever plateau pressure is, you basically subtract the PEEP, and your driving pressure, the pressure with which you're getting the oxygen or the air to the patient, should be less than 15. In some patients, because those patients are difficult to basically ventilate, don't panic if their oxygen saturation is around 88. That's okay. PO2 up to 55, that's also okay. Try not to panic and play too much with the ventilator, and try not to panic and basically lose hope, because those patients they end up having significant lung disease, and unfortunately they stay sick for long periods of time. Some people stay on the vent for 2 weeks plus, so be very patient with them. So you intubated them, you're ventilating them, you're monitoring how they're doing ABG and clinically. Make sure when they are in the H type that they're prone, laying on their abdomen for 12 to 16 hours a day. And if even with proning will help you recruit more lung tissues, and it will decrease resistance and improve your compliance, and hopefully your pressures will drop. If you're still noticing that the patient has high pressures in the lung, you could consider using paralytics, which is basically medications to relax everything, and you can take over breathing, relax their respiratory muscles, and then you can take over ventilating them without any resistance from the airways or just wall or anything causing your pressures inside the lung to be higher, because as we said, pressure is a very important factor in ventilating. As we said, in anticoagulation is considered in a lot of the ICU patients who we have issue ventilating them. The typical patient that we will consider systemic anticoagulation for is someone who is a type H disease. Those patients in postmortem evaluations were found to have a lot of thromboembolic disease in their pulmonary circulation. So anybody who you're having issue oxygenating them, despite proning, paralytics, their D-dimer is elevated, usually we would say more than 10, and you have issues ventilating them, you put them on systemic anticoagulation. Nitric oxide inhaled, it's used for ARDS patient, that you use it through the ventilator itself. It does help temporarily, So it would give the patient maybe 2-3 days of improved oxygenation, but then after that it will not work anymore. But those 2-3 days could buy the patient some time until the patient start to recover somehow. Besides, the basic care for any intubated patients is to make sure that they are on enough analgesics and enough sedatives. Those patients يعني تخيل نفسك انت خدت لك انبوبة في حلقك, you definitely would appreciate analgesics, mostly through a drip. Fentanyl is a good agent to be used, or hydromorphone or morphine. Ideally fentanyl because it's short acting. Sedatives also are to be used whatever is available. Propofol is a good agent. Midazolam is another agent. Dexmedetomidine is also an ideal perfect agent too. GI prophylaxis, make sure that they are not developing a stress ulcer. Put them on proton pump inhibitor, omeprazole or esomeprazole or any of them. They also need to have an NG tube. We need to monitor their urine output, daily weight, turning them, skin care, oral care, eye care, to make sure that we are not causing any harm to the patient. Because even if you manage your ventilator 100% well, if you are not monitoring those elements, the patient will still not make it. So make sure that you're monitoring all of those agents to improve your outcome with the patient and to actually make sure that the patient will make it with a good overall health, not make it with a bad ulcer to his or her spine or an eye ulcer or something like that. So what's next from here? Some patients will improve, but you have to be very patient with them because it might take them, as I said, up to 2 weeks or more to improve. Some patients will deteriorate and you will consider them for ECMO, which I don't think is available in Sudan. Those patients will unfortunately end up dying. Extracorporeal membrane oxygenation, which is basically like dialysis كده بالنسبة you take the blood out and you oxygenate and you put it back. Some people will go that route and they'll unfortunately في السودان عندنا حيموتوا. لكن في ناس who get better, but you have to be patient because it takes them long time to improve, up to 2-3 weeks sometimes to get better. Be patient with them. I think we are almost done with the management of respiratory failure. So you can break with this. People take different roads seeking fulfillment and happiness in life. And just because they're not on your road, it doesn't mean they've gotten lost. Some wisdom. عشان ما تقولوا حار منكم من حاجة. طيب, after we spoke about respiratory management or respiratory failure management, and I think I'm already over an hour. So I'll try to take maybe 15-20 more minutes because I have a practice case at the end and I still did not talk about the cardiac complications, so I'll try to move quickly. So management of shock, of course, as we said, an arterial line would help and the central venous catheter would also be very indicated to monitor their volume status and their blood pressure very closely besides cardiac monitoring. If they need fluids because their central venous pressure is less than 8, as recommended by the sepsis campaign recommendations or sepsis campaign protocol, CVP of 8 to 12. So if their CVP is less than 8, then you of course want to give them IV fluids. If it is not, then you put them on vasopressors to increase their vascular tone and support their blood pressure. Noradrenaline or norepinephrine is the preferred agent. If the patient maxed out on norepinephrine and they're no longer improving with it, you need to start them on another vasopressor. But before you do that, actually you start them on the second pressor, but at the same time you have to give them a dose of steroid, hydrocortisone, and you start looking for other causes of hypotension. Bacterial infections, EKG and troponin looking for evidence of myocarditis. If there is anything here, then you of course get an echo done. Lactate will just give you the degree of tissue hypoperfusion. because it's a marker of anaerobic oxygenation or anaerobic, metabolism. You maxed norepi, you can start the patient on vasopressin. If the patient maxed on that, they're probably not coming back, but you can give them the benefit of the doubt and start them on a third pressor like epinephrine. Avoid the vitamin, avoid dopamine, because those patients, unless if you think this is a cardiogenic shock and you want to support their heart with the vitamin, then you maybe, but it's mostly uh, vasodilatory septic shock picture. So use norepi. Your second agent should be vasopressin. If the patient, norepi is recommended as number one, but if the patient, let's say, has significant tachycardia, heart rate 160, 170, fast rate, and you don't want to give them anything with any beta adrenergic activity, then you just start with vasopressin. But otherwise, norepi or norepinephrine, noradrenaline is the number one agent. The COVID-specific therapies at this point tend to become more irrelevant because they're not that effective. The only two that are effective, I would say, actually, I just listed the ones that are maybe effective and the one that we might use. This is a one that we have in Sudan, so we might use this line. Completely useless at this point in the ICU patient who is this sick. This is completely useless. It will just make you more prone to complications, including QT prolongation and increased risk of malignant arrhythmias. What you can consider, I don't think we have this in Sudan. We probably don't have it in Sudan. Remdesivir, it did show some benefit for people who were sick, people who were even on ECMO. So if it became available, you can consider that. Definitely consider them for convalescent plasma. It also showed some benefit in severely ill patients, and Dr. Muhammad Hassan will talk about more, give you more details about that. This is something that is also studied to help because we said they have high levels of interleukin 6, which is causing most of the uh, inflammatory process, but it's not available for Sudan, للأسف. Some people use this and systemic steroids to suppress the immune response or the cytokine release. Since we don't have interleukin, someone might argue we could use some steroids, but the studies for and against the use of steroids are the jury is still out on systemic steroids. In early disease, in people who have less severe disease, definitely don't use steroids because you will impair the patient's ability to mount a good immune response to halt viral replication. But if the patient is already past the viral replication point and they are at the cytokine storm point and the hyperinflammatory condition, would it be better to give some steroids? We could debate that. Since we don't have IL-6, I won't be mad if somebody used the steroids. We usually, the people who uses steroids usually would do 40 milligram of methylprednisone IV twice a day. But we do have an evidence-based session by the end of those lectures, and we should be looking at all the studies, examining all the contradictory points and points of importance, and hopefully we will have a study or two discussing steroid use. Anticoagulation, as we spoke about, the ideal candidate for it, someone who is on mechanical ventilation, you're having a hard time ventilating them, they're likely type H disease, and their dimer is elevated. Anticoagulation would help decrease mortality in some small studies that I saw by significant numbers actually. So besides monitoring management of shock and respiratory failure, you also have to monitor and manage other complications. Renal complications were discussed by Dr. Randur. I'm going to talk about the cardiac complications in a brief 2-3 slides. And coming in the next session is hematological and neurological presentation complications. So this is the end of part 1. Part 2 is cardiac complications. Part of the cardiac complications, as we said, is due to the cytokine release and the cytokine effects on the heart, on blood vessels, and the cytokine causing endothelial dysfunction and endothelial damage, which could lead to plaque instability and rupture, which could end up giving you an acute event, acute coronary event, whether a STEMI or a non-STEMI, directly related to COVID-19. Sorry. Or it could be not something related to the cytokine storm. Another thing that's related to the cytokine storm is vasodilation. And when you have vasodilation and hypotension, you get poor flow to the cardiac myocytes and relative ischemia. This relative ischemia, if you have underlying CAD or if it was pretty profound, especially in the especially due to the significantly increased myocardial demand and myocardial work, you could end up with a type 2 event or a type 2 ischemic event. Type 2 usually would just mean there is imbalance between flow and demand. So the flow is low because of hypotension and the demand is high because of the increase in sympathetic drive and tachycardia and increase cardiac work. Another thing, as we said, there is ACE2 receptors in the heart, so direct infection causing myocarditis and myocardial damage. And the myocarditis in turn could cause heart failure and or arrhythmias. Heart failure could also be caused due to, as we said, the increased cardiac work. So this is a list of the cardiac complications. Number 1, as we said, endothelial dysfunction with disruption of the plaque with thromboembolic phenomena and type 1 MI. Increased myocardial work and decreased oxygen supply or blood supply, leading to supply-demand mismatch and type 2 MI. Another thing is cardiomyopathy, either due to ischemia from type 1 or type 2 events, or myocarditis, or both, with decreased ejection fraction with all its consequences and cardiogenic shock and stuff. Also, arrhythmias, most commonly due to the lung disease and the thromboembolic phenomena in the lung. The most common arrhythmias in a lot of the studies that I came across was PEA. There is also asystole, there is VTAC, mostly polymorphic VTAC, but also monomorphic VTAC and VFib. Usually, malignant ventricular rhythm issues are due to issues with blood flow, which, as we said, are definitely present, or due to cardiomyopathy. PEA asystole is usually due to the lung disease itself. Polymorphic VTAC is common due to too much medications that we use that could prolong the QT interval. Mostly is hydroxychloroquine and azithromycin. So the combination of both of them is definitely not recommended at all. Even the use of a single one of them is discouraged if someone has a prolonged QT of 500 or more. So be very careful there. And then also, as we said, heart failure from all the high demand and so this is, as we all know, is the polymorphic ventricular tachycardia, or the Torsades de Pointes, or the polymorphic VT. And it's mostly because of the QT prolonging agents that we use. How can we support the heart? Of course, hypoxia definitely would lead to ischemia, arrhythmia, and heart failure and other stuff. So definitely management of hypoxia. Also, hypotension is also something that would lead to worsening increased demand plus diminished supply, and would also make you more prone to heart failure, make you more prone to ischemia, make you more prone to arrhythmias. Hypoxia would also make you more prone to ventricular arrhythmias. So management of hypoxia and hemodynamic support. Also correction of electrolyte derangements, mainly magnesium and potassium. Always keep your patient's magnesium more than 2 and their potassium more than 4. Their potassium doesn't have to be more than 4, maybe 5 or something, but just between 4 and 4.5. If they are lower, give them supplementations. Avoid medications that prolong the QT, as we said, especially in people who have baseline QT prolongation. Hydroxychloroquine, Zithromax, anti-emetic medications. Most of the emetic agents do cause prolongation of the QT if the patient is on any antipsychotics, antidepressants, some antibiotics like ciprofloxacin. A lot of agents do cause the prolongation of the QT, so be careful. Monitor serial EKGs and troponin in patients in which you suspect QT prolongation, rhythm issues, issues with ischemia, cardiac ischemia, or myocarditis. Treatment of arrhythmias as they develop. We usually would say, an ideal agent for those patients and their ventricular arrhythmias is amiodarone, but unfortunately most of them have prolonged QT, and the next best would be lidocaine. However, I don't think lidocaine for arrhythmias dosing is available in Sudan, so we might be stuck with amiodarone. So always make sure that your patient's QT is not prolonged, because hydroxychloroquine or chloroquine is borderline useless, and amiodarone is very important in management of arrhythmias if they develop. So I would not use an agent that could prolong their QT like hydroxychloroquine or azithromycin and end up depriving my patient from the chance of using a life-saving drug like amiodarone. In some cases who did not respond to amiodarone, did not respond to lidocaine, we had a patient that the cardiologist ended up having to use IVIG for that patient, which we will also see in Guillain-Barré syndrome, that IVIG were used also for that management. And then, of course, management of heart failure, which would mainly be hemodynamic support and volume management. Making sure blood pressure is better through the butamine or any vasopressor, and making sure that you're taking volume out to load the system either through diuresis or dialysis. But as far as giving them any other medications to prevent cardiac remodeling like ACE inhibitors or beta blockers, you can't do that in the acute phase while they're hypotensive and critically ill. As far as acute coronary syndrome in the COVID pandemic era, usually there is usually delay from the time that you get the patient to the time you get the patient to the cath lab for an intervention, and that's due to the system clog up due to the COVID-19. So if you anticipate that delay to be 60% or more, give the patient fibrinolytics. If you do not anticipate the delay to be 60 minutes or more, then you send them for primary PCI. That's the basic idea behind this table. If you decide you're gonna use fibrinolysis, which we do use, I think Altiplase is available in Sudan and streptokinase. If you decide to use either, initiate treatment as soon as possible after the diagnosis, and of course you also add antiplatelets, aspirin, clopidogrel. We sometimes would hold on clopidogrel if the patient is going to need an urgent coronary bypass, but I don't think that's the case in Sudan, so load them with aspirin and clopidogrel. Also, if if there is any delay between fibrinolysis and PCI, you could bridge this time until they get their revascularization with anticoagulation. The last thing is if the patient after fibrinolysis ended up having heart failure or went into shock or had recurrent ischemia or evidence of reclusion after successful fibrinolysis, then those are the people you send them for emergency PCI or percutaneous intervention in the cath lab. This was ST elevation MI. For non-ST elevation MI or non-STEMI in the COVID-19, you divide them into very high risk, and lower risk. So very high risk patients are patients who have non-ST elevation MI with elevated troponin and also hemodynamic instability like cardiogenic shock, acute heart failure, recurrent or ongoing chest pain despite full medical therapy, life-threatening arrhythmias, and then if anybody developed any mechanical complications of MI like acute MR or ventricular septal rupture, or recurrent or intermittent ST elevation, those patients, they go for immediate invasive strategy. As if they have a STEMI, they immediately go to the cath lab for a PCI. If they have none of those major high risk features, but they have EKG changes and elevated troponin, or if they have recurrent symptoms, then of course after those patients you have to send them for also invasive PCI, but within 24 hours. Within 24 hours. So you don't have to do it emergently within an hour or two, but you have within 24 hours. If they have elevated troponin but no EKG change, but they have, let's say, diabetes, kidney disease, low EF, or angina, then you use non-invasive testing to kind of see whoever is higher risk and needs invasive ventilation. So you send them basically for a stress test after they improve. After they improve, you send them for a stress test. In those patients here, there is room for testing for corona and figuring out if they're positive or no and preparing yourself. In those patients, they're very critical. There is no room to wait. Otherwise, you will lose them. So we're done with the presentation. Let me go to the comment and see if people are still... I do have a case to practice, but I'm not sure if this is appropriate or no. I'm going to go to the comment and see. I'm just going to wait for... can maybe 2 or 3 people just comment and let me know if we're interested in doing this case, or should we just... Has it been too long already? Should we just go to the hematological and neurological complications? There is a question, Dr. Ahmed Hadi, is pericarditis common or no? It's definitely not very common. I mean, myocarditis is about 16% to 30% in some studies. Some of the myocarditis patients end up developing myopericarditis with ST elevations. So this is something that we need to pay attention to. Whenever you see an ST elevation, be careful, because it could be just from the myocarditis. From the myopericarditis, and we had one patient who had this similar problem, went to the cath lab, clean coronaries. Classic ST elevation, but when they went to the cath lab, there was clean coronaries. Of course, it wasn't a classic ST MI, but in peacetime, we would take that patient to the cath lab. I think in corona time, we have to be very more careful in screening our STEMI patients. Some bodies recommend doing an echo, looking for wall motion abnormalities before, like a bedside ultrasound, looking for wall motion abnormalities, examining the echo, the EKG very carefully, looking at the risk factors that the patient has. Could this really be a STEMI or no? Because you will take them to the cath lab, expose healthcare workers and stuff, and then end up being a clean cath. Um, so, so I have one vote to go to neurological complications. Any other votes? Okay. So I will conclude at this point. Thank you very much, and I apologize for taking such a long time. And we will go to neurological and hematological complications, and hopefully maybe we can get another chance to do this practice case to solidify what we learned about the management. And thank you for your time.